Welcome everybody to Geriatric Grand Rounds. Few announcements before we get to today's presentation. Next Grand Rounds will be February 16th, and our speaker will be Dr. Peter Pressman in neurology, and he's going to be talking about Alzheimer's treatments, especially the new Aduhelm treatment. Next Journal Club will be February 10th, and our presenters will be Dr. Susie Kim and Dr. Sarah Beck. Other announcements, there is a division meeting after today's presentation, so we'll be trying to end fairly promptly so people can join the division meeting at 8:30. Following today's Grand Rounds, you will receive an email with a link to today's presentation recording, as well as a copy of the PowerPoint, and there will be a link with an online evaluation, so if you could please take a couple minutes to fill that out and return it, we'd really appreciate it. Please feel free to submit questions anytime during the presentation in either the chat or the Q&A boxes, and we will hopefully have time to get to those at the end of the presentation. So I'm very happy to introduce our speaker today that most people know quite well, Dr. Sunny Linnebur. Dr. Linnebur is a professor at the University of Colorado Skaggs School of Pharmacy and Pharmaceutical Sciences. She got her Doctor of Pharmacy degree at the University of Kansas with highest distinction, completed her residency at the VA in Denver, and then a PGY2 residency at University of Colorado. And since 2001, she's provided clinical pharmacy services in geriatrics at the Seniors Clinic, where she also precepts pharmacy students and residents. Her research and clinical areas of interest include transitions of care, cardiovascular disease, health promotion, osteoporosis, vitamin D, dementia, and urologic disorders. She's an active member of the American Geriatric Society, where she serves on the expert panel for AGS updated Beers criteria and is also past president of AGS. She's also a member of the American Board of Internal Medicine Geriatric Medicine Board, and we're thrilled to have her here today to talk to us about avoiding medication overload in older adults. So Dr. Linnebur, take it away.
Thank you so much, Carrie. I appreciate that. And welcome everyone. This morning, I'm going to talk about constructs for avoiding medication overload in older adults. If the slides work here. So the first slide that I wanted to show was just my disclosures. I don't have any relationship with any drug therapies or anything like that, but I am a member of the expert panel on the AGS Beers criteria update for 2022 and was a member of previous panels. So today I'm going to talk about consequences of medication overload that may be found in your patients and noticed by their families. I'll talk about some shared decision-making principles and strategies when avoiding adverse drug events, and then some tools to help you with de-prescribing. So what is medication overload? Often we think about polypharmacy as probably the #1 thing that our older adults will face in terms of drug therapy, but a couple of years ago, a group came together and worked with the Loan Institute and published a report about medication overload in older adults. And when we think about medication overload, this really is simply defined as having medications on board that have more harm than good, or the harm outweighs the benefit for the patient. And there are some threats that they collected in terms of data that are affecting our older adults. And obviously in the times of COVID, people have different priorities, but medication overload has been a concern amongst geriatricians and amongst those working with older patients for quite some time. But in 2018, it was found that 5 million older adults sought medical attention for adverse drug events. 42% of older adults take 5 or more prescription medications, which increases the risk for medication overload. Crazy enough, over the last 20 years, there was a 200% increase in polypharmacy, which we typically define as 5 or more prescription medications. In 2018, there were 280,000 hospitalizations in our older adults due to adverse drug events. There was $62 billion spent in preventable hospitalizations over 10 years, and it's estimated that there will be 150,000 premature deaths in the next 10 years due to adverse drug events. So again, in the context of COVID, I think sometimes we may disregard some concerns we have with other preventable medical conditions, but this one is one that as a pharmacist, I'm very passionate about. Other consequences of medication overload include things like patient level consequences. They're confused about their medicines. They have stress associated with this and anxiety about their medications. It takes significant time for them to be able to take all of those medicines and to manage them, which increases drug costs and costs of medication management if perhaps they need assistance. Other consequences are medical consequences like delirium or falls or mortality associated with multiple drugs. And then at the clinician level, this is where often Danielle and I are helping, is with the confusion on what is the patient actually taking. And this leads to so many inefficiencies. Everyone practically on the team is involved frequently on patients trying to figure out what are they actually taking at home, what do we think they're taking, and how do we assess that to prescribe new medications and to de-prescribe. And then at the health system level, obviously directly, there are high costs of drugs, prescription drugs and over-the-counter drugs, and then burden of medication management to the system and to society. So I want to take a patient journey with you, Gary, who is described in this Lone Institute report, and I think really is a good example of how you can see that medication overload can affect a patient and how we could perhaps do things differently. So Gary is living in Ohio with his wife. He's a retired teacher. He loves fishing. And at age 65, Gary is prescribed medication for high blood pressure and high cholesterol. At age 72, Gary is diagnosed with type 2 diabetes and prescribed medication to control his blood sugar. Next, updated guidelines put Gary's blood pressure in a higher category now, and he's prescribed another medication for blood pressure treatment. After this, Gary feels lightheaded and he falls at the grocery store, breaking his leg. At the hospital, he's prescribed an opioid for his pain. Gary has trouble sleeping and he feels depressed, and his primary care provider, unaware of the opioid prescribing, prescribes meds for sleep and depression. Later, Gary gets the flu and becomes dehydrated, making him more susceptible to drug side effects. Dizzy and confused, Gary rear ends the car in front of him at a stoplight. His family believes he is showing signs of dementia and may not be safe at home. End result here is that with his medication overload undetected, Gary is placed in a nursing home and dies 5 years later. I'm sure many of you can think of patient examples where this cascade of events occurred and patients spiraled into perhaps low quality of life and an ending to their life that they did not expect. But this doesn't always have to happen. So let's look at ways that this could have potentially been altered. So at the time that Gary was diagnosed with type 2 diabetes, his provider explains both medication and lifestyle changes, and Gary opts to first try lifestyle changes. When his blood pressure is high, his provider notes that older patients like Gary may fall outside the new guidelines. They discuss the risks and benefits of a new medication and decide not to prescribe, potentially keeping him at a higher blood pressure that may not provide as much cardiovascular benefit, but still is tolerable for Gary. Then when Gary breaks his leg and goes to the ER, instead of prescribing opioids for that fracture, they choose ibuprofen instead. Now, as we know, ibuprofen has risks in older adults as well, but potentially may not be as risky with certain adverse effects as an opioid. The primary care provider is also informed of what happened in the hospital and about the fall and the new medication. And that primary care provider can then make more effective changes with Gary when he has symptoms of depression. At that point, his provider talks with Gary and learns his brother has died. She refers him to a grief counselor and provides sleep hygiene information instead of medications. Dizzy and confused, Gary does rear end the car in front of him at a stoplight, but at this point, instead of immediately suggesting that and agreeing with his family that he be placed into an assisted living or nursing home, Suspecting medication overload, the doctor performs a prescription checkup and de-prescribes unnecessary meds, and Gary lives 10 more years at home. So, this is an example of a patient scenario where we can make changes, perhaps affecting in a positive way the patient's quality of life. Now, Gary, you can see here in either scenario, we estimate Gary's going to live 5 years or 10 years. So this is not going to greatly extend his life expectancy, but perhaps make his quality of life higher. So what I want to talk about are some principles and pearls about prescribing and de-prescribing and facilitating this in older adults so that your patients don't have this mountain of medication that they're trying to balance. And when we think about prescribing in older adults, one of the first things that I think is really important and learners should be thinking about is first do no harm, or primum non nocere, which is a major tenet of medicine. And when we think about older adults, harm is so easily taken by medications. And so first doing no harm should be our first thought. When we think about medication overload, there are 4 main areas that we can avoid in terms of first doing no harm. So the first category is never necessary prescribing. The second category is indicated but not beneficial prescribing. Then we think about no longer necessary prescribing. And then finally, unnecessary OTC and supplement use. So practice tip number 1, let's start with the never necessary prescribing and utilize the prescription checkup in order to do this. So when we think about never necessary prescribing, this is where the Beers list fits in. So drugs that have a high risk and a low benefit for our older patients, or with safer alternatives. Also, drugs that are intended to be short-term, but are continued long-term. For example, a proton pump inhibitor for ulcer prophylaxis or treatment, and albuterol that may be used for a cough, but is not indicated long-term for that patient. Also, we think about drugs initiated as part of the prescribing cascade. So just a quick update on the Beers criteria. It is being updated currently for 2022, but we are expecting to have the same general tables. So table 2, potentially inappropriate meds that should be avoided. That's for all patients, drugs that really have that high risk, low benefit. Table 3 is where we think about those disease drug interactions. So medications that should potentially be avoided if a patient has a certain condition like delirium or dementia. Table 4 is potentially inappropriate meds to use with caution because the data are not quite as strong to put them into table 2. Then table 5, drug-drug interactions, and table 6, renal dosing. So these are all ones that you would think about as providers who work with older adults, but antipsychotics, benzodiazepines, skeletal muscle relaxants, and the Z drugs like zolpidem for insomnia. Those are drugs that have a general high risk and not a benefit that is going to reach that risk point. So those should be potentially avoided in all older adults. Table 3 is that drug disease syndrome interaction. So for example, if patients have dementia or cognitive impairment, we typically want to be avoiding anticholinergic drugs like diphenhydramine or oxybutynin. We want to avoid benzodiazepines or Z drugs or antipsychotics because those can potentially worsen the dementia or cognitive impairment. Other conditions that we frequently see interactions with are, for example, heart failure. Patients may take an NSAID, and although one dose of an NSAID may be not affecting their edema or their heart failure, multiple doses or consistent use of an NSAID can send the patient to the ER with a heart failure exacerbation. So a lot of these agents that you'll see on here are drugs that we do use in older patients. So for example, in the falls category, you'll see SSRIs and SNRIs, and we may need to use those agents for someone with depression, but we need to recognize that fall risk is something that our patients may have increased risk of due to collective things, but partially also due to their antidepressants. And so again, the benefit there may outweigh the risk of increased falls. but we have to be thinking about monitoring for it. So going back to Gary, 6 months after the death of his brother, Gary still has trouble sleeping and feels increasingly depressed. He has been working on sleep hygiene and speaking regularly with a grief counselor. Despite this, he is not caring for himself. He has stopped cleaning his house and is increasingly withdrawn. So which of the following medications would you consider prescribing for Gary? This is a rhetorical question because we're on Zoom, but we have A, quetiapine, B, zolpidem, C, citalopram, and D, amitriptyline. So if you were to take your geriatric board exam, this may be a question that you would see. And when we think about the correct answer, A, B, and D are all on the Beers list and have increased adverse effects in older adults. So C, citalopram, would likely be the correct answer. One thing to note is that citalopram can increase the QTc interval. And so we think about that being something where we may need to choose a different antidepressant as well. So moving on, practice tip number 2 is avoid the prescribing cascade. And when I talk to patients about this, I usually try to use the book, There Was an Old Lady Who Swallowed a Fly, to illustrate the prescribing cascade. So when we think about there was an old lady who swallowed a fly, she first swallowed the fly and she thought she might die. So she swallowed a spider to catch the fly. And after that, she had to swallow a bird to catch the spider. And to catch the bird, she had to swallow a cat, and so on. And so we think about that old lady who took a medication perhaps, and she had a side effect to that medication. So we prescribe a new drug to treat the side effect of the first drug. And then that second drug causes a side effect. And now we're prescribing a third drug to treat that side effect of the second drug. So it really does follow this same principle. And so what we want to do is first eliminate the fly. So here's an example that was illustrated in the last year in the medical literature, which I frequently see in clinical practice. Amlodipine is a great drug for blood pressure management. It works well. It is relatively well tolerated, but one of the side effects is edema. In this particular JAMA internal medicine study, they found that older adults taking calcium channel blockers like amlodipine are 2 to 3 times more likely to be prescribed a diuretic in the next 90 days than if prescribed an alternate drug. And so that diuretic is typically because of the side effect of edema. So here's the prescribing cascade, and this is just one illustration. We have a patient prescribed amlodipine. They call you back a couple weeks later, I'm having some edema. They're prescribed furosemide. Furosemide causes hypokalemia, so we add on potassium chloride. Potassium chloride is really difficult to tolerate on the stomach, and they have upset stomach and heartburn, and they call you, they're prescribed a PPI. They take the PPI for some time, and it's helpful, but now all of a sudden they have C. diff, and they're being prescribed vancomycin. And this cycle can actually keep going past the vancomycin. But you can see that this prescribing cascade can continue on. And really what we want to do is stop the amlodipine. So in terms of preventing and adjusting when a patient has a prescribing cascade, the first thing to do is identify that it is the prescribing cascade. And so for any new symptoms, even if things like a cough, for example, it's, if reasonable, investigate drugs as the cause. Ask your pharmacists like Danielle or I to review drug databases and the primary literature. Although many side effects are predictable and easy to identify, a lot of side effects in our older adults are pretty rare. And so we may need to review the medical literature in order to detect it. Also, a temporal relationship is really important, because if the patient has the symptom before they start the medication, it's probably not the drug. Laboratory measurements are sometimes helpful. We may be able to do a serum drug concentration, or we may need to check something like a TSH, for example. And so that might be something to think about. And then in order to avoid going down that prescribing cascade, we really want to think about discontinuing that initial drug or reducing the dose and then monitoring for symptom resolution. Sometimes we need to consider drug rechallenge, but most of the time not. So here are some other examples that I see frequently in clinical practice. We have sertraline, a first-line therapy SSRI for depression, but it causes diarrhea. in many patients at a higher level than other antidepressants. And so typically then we see patients prescribed loperamide. And you can continue down this prescribing cascade when they get constipated and are now prescribed a laxative. Spironolactone and lisinopril may be indicated for heart failure, but they can cause hyperkalemia, especially in patients with reduced kidney function, and now they're prescribed Kxalate. Carvedilol is a evidence-based treatment of heart failure and hypertension, but carvedilol is kind of what we would consider a dirty drug. It has effects on multiple receptors. So carvedilol is a beta receptor antagonist or a beta blocker, but it doesn't just block beta 1 receptors, it blocks beta 2 as well. And so it can cause bronchoconstriction in our patients who are then prescribed albuterol or even things like COPD inhalers. Carvedilol also blocks alpha receptors. So it's an alpha and beta blocker. And as an alpha blocker, that might be helpful for men who have enlarged prostates. But in women, it can cause incontinence. Specifically, stress incontinence can worsen. And often we see oxybutynin prescribed after carvedilol for incontinence. Cholinesterase inhibitors like donepezil for dementia may be indicated for your patient, but they have side effects as well. And often that acetylcholine increase works on the bladder and causes bladder spasms or urge or overactive bladder symptoms. And then the patient's prescribed oxybutynin or other bladder medications, which can often even have a drug-drug interaction with their dementia med. So instead of adding on the drugs on the right-hand side, we'd want to change the drug on the left-hand side. So let's talk about a new case. We have June. June's 85. She's a retired librarian who loves reading. She's widowed and lives with her daughter in Denver, and she has a list of medical problems and medications that is long. So you can see here, I think she has 11 medical conditions or 10, and her medication list is quite long. So she has mild cognitive impairment, type 2 diabetes, hypertension, CKD, dyslipidemia, hypothyroidism, anxiety, constipation, AFib, and OA of the left hip. But her medication list has 18 medications: amlodipine, metoprolol, levothyroxine, simvastatin, gemfibrozil, metformin, glyburide, apixaban, citalopram, 2 insulins, omeprazole, ibuprofen, acetaminophen, Tylenol PM, Docusate, aspirin, and a multivitamin. Not uncommon to see this long of a medication list. So June's mild cognitive impairment seems to be progressing, and she's worried about dementia and wants to start a treatment. So which of the following would you assess first prior to starting donepezil? Would you check a TSH, a hemoglobin A1c, vitamin B12, or Tylenol PM use? So really you could check all of these things, and I think they would be important. If we were doing a memory med review in the seniors clinic, we would recommend checking all of these things. So the TSH is important because she's on levothyroxine, and perhaps her thyroid function is impacted by non-adherence to her levothyroxine. Hemoglobin A1c is really important because she could be having hypoglycemia. A vitamin B12 is important because she's on a PPI, and we know that increases the risk of deficiency in B12, which is also pretty common in general with older adults and can in fact impact their cognitive function. And then of course, Tylenol PM use is important because she has that on her list, and it includes diphenhydramine. And we want to know, is she actually taking it or not? Another question, everything comes back normal. So we checked all those labs, and her MMSE shows mild dementia now. She wants to start donepezil. What her vitals and labs include a blood pressure 152/78, heart rate 68, serum creatinine 1.4, and K 3.5. So what should be monitored to prevent another prescribing cascade from occurring with donepezil? Should we check your potassium, heart rate, blood pressure, or serum creatinine? Well, this is where we need to think about, what does donepezil do outside of the central nervous system? So donepezil is a cholinesterase inhibitor, and it increases acetylcholine in the whole body. And what that does is when the acetylcholine acts on the vagal nerve, that decreases heart rate. And so clinically, I see this very frequently. We have patients who have bradycardia related to donepezil. And often it's because they're on concomitant beta blockers like June is, where they have a baseline blood pressure that's controlled but low because they have AFib and are on a treatment for it. So we really need to check her heart rate after she is prescribed. And if her heart rate starts below 60, then we would avoid prescribing it. Donepezil and other cholinesterase inhibitors have been shown to increase the risk for falls and fractures related to bradycardia, also ED visits and pacemaker insertion. So clearly we would want to avoid that prescribing cascade. Moving on to the next category, the indicated but beneficial prescribing. When we think about indicated drugs, there are millions of indicated drugs for our older patients. And so it's more like, what is most indicated for our patient and what are they interested in? But sometimes drugs lose their effects or they only have modest benefit. And you can think of many of these agents, but some examples are the dementia drugs I was just talking about have very modest benefit. Sulfonylureas may wear off as a person's pancreas becomes non-responsive with long-term diabetes. And antimuscarinics for urinary incontinence are modestly effective as well and may not be helping our patients. Other indicated but not beneficial prescribing could be drugs where they're non-adherent. I can't tell you how many patients are non-adherent to metformin. And while I want them to take metformin because it has good data and it's very inexpensive and effective for diabetes, it causes a lot of GI side effects. And I've seen this increasingly in our older adult population where they have significant diarrhea or upset stomach and they're not actually taking the metformin that we think they're taking. Bisphosphonates also are drugs that patients are often non-adherent because they take them once a week and they don't really see the effects on their osteoporosis. So they forget and may not be filling that medication at the pharmacy. And then COPD inhalers, it's just really challenging for patients to remember to do inhalers unless they're having significant breathing difficulties. And then they often just turn to their albuterol. So often the more controlling medications that we may see, like the LAMAs or the LABAs, they are non-adherent to. Other drugs that we need to think about are ones that have drug-drug interactions, so they're not absorbed. So for example, if a patient takes a PPI and they're taking calcium carbonate, they're probably not absorbing the calcium carbonate, which needs acid for absorption. So we'd want to use calcium citrate instead. Drugs that will not be effective or show benefit in the remaining lifespan of the patient may need to be reevaluated as well. So for example, a statin for primary prevention, we may think about that if a patient has not had a cardiovascular event and they have a short life expectancy, we wouldn't initiate a statin. And in some patients, we would consider de-prescribing. So practice tip number 3 related to this, when initiating drugs, consider the goals of care and time to benefit. And this is a picture of myself and my grandmother who passed away this summer, just shy of 102. This was at her birthday when she turned 100. And you can see her, she actually lived independently until she was 100. So we, her goals of care may be different than a patient who is 100 but living in a nursing home, for example, or it may be different than someone who's 80 and really active. So when we think about goals of care, you guys are experts in this, but we want to be thinking about how frail is the patient. Are they more interested in prevention or palliative care? And what are their quality of life goals? And when we think about this, we want to consider the time to benefit. So if the drug is not going to be effective at reaching the therapeutic benefits before the patient is expected to pass away, then it's not worth starting that medication. So one of the ways to do this for prevention, things like immunizations or screening, is to look at the ePrognosis website and compare benefit to life expectancy. But when we think about drugs, one of the ways to look at drug therapies, when you look at a clinical trial and the drug has been FDA approved, there's often a Kaplan-Meier curve, and you can compare the time where the placebo and the drug therapy really start to split and those curves split. And that's where the benefit starts to be significant for patients. And so at that point, you can visually see where that and estimate that time to benefit. But sometimes clinical trials are published. And for example, with statins, one was recently published evaluating the time to benefit. So when you compare treatments, for example, statins have a time to benefit of about 3 years for the patient. So if they're going to live 3 years, it may be helpful for certain patients. Whereas prostate cancer screening is about 10 years. So we may consider not ordering a PSA in a patient to evaluate for prostate cancer if their life expectancy is not estimated to be 10 years. Immunizations are in great contrast. They work in about 2 weeks, but they have side effects immediately. Pain treatments have side effects immediately, but also benefit immediately. Hypertension treatment benefits on mortality and stroke don't occur for about 6 to 12 months, but hypotension occurs immediately. Similarly, bisphosphonates take about 12 months to work and impact fracture reduction, but cause side effects immediately. So we need to be thinking about this and sharing it with patients in terms of how long it will take to expect a benefit from that drug. Hypoglycemic agents for diabetes cause hypoglycemia immediately, but benefit could be months or even years later in our older adults. And then aspirin I have in those 60 to 70 because recently the USPSTF came out with a recommendation, it's in draft form, to not use aspirin for primary prevention unless the patient is less than 60. But previously we had less than 70. So some of our older adults fall in that group. But side effects occur immediately from aspirin, and CV protection takes 1 to 2 years to affect the patient. So it's important when we think about time to benefit and time to harm for these drugs, and we think about the patient's life expectancy, we need to be balancing these things. Moving on to the next category, no longer necessary prescribing. We think about drugs that are indicated for a certain time frame but never stopped. So for example, bisphosphonates may be indicated for 5 years. Patient can then have a drug holiday, certain patients, but we may forget to do that. Anticoagulants are exactly the same way. Patient may have a VTE, they're indicated for 6 months of an anticoagulant, but no one really has time to check on the timeline, and maybe they're continued on it for a year when we could have stopped it earlier. Antiplatelets are one that I see frequently. There's often confusion. When did the stent actually get placed? How long have they been on their dual antiplatelet therapy? But do they really need 2 antiplatelets now? If it's past a year, maybe we can cut that down. Proton pump inhibitors for ulcer treatment are another example. Antidepressants. Patients may have remission of their depression, and we often may not reevaluate their antidepressant. Metoclopramide is not prescribed very often, but has a 90-day dosing and then black box warning beyond that. And then estrogen I see less frequently. Other drugs that are no longer necessary due to changes in goals of care. So these are the drugs that we may think about de-prescribing. Vitamins and minerals are one that I see so frequently amongst our older adults, and we may need to keep some vitamins and minerals like vitamin D or vitamin B12, but other ones we could potentially think about discontinuing. And then finally, drugs used to treat a condition too aggressively. So they're no longer potentially needing their insulin because their goals of care have changed, or their hypertension treatment, which we were using to reduce their mortality and reduce their risk of stroke, may no longer be necessary because they are now hypotensive. So looking back at June, she starts the donepezil and we add it to her 18 drug regimen. Now she's at 19. And she's tolerating the donepezil well, and we check more labs and find her LDL's 58, HDL 79, trigs 50, hemoglobin hematocrit 14 and 40, MAG is 1.7, and her LFTs are within normal limits. So which drug is likely no longer necessary for June? Is it the apixaban, gemfibrozil, omeprazole, or acetaminophen? Well, when we look at the list, she does have some pain, so acetaminophen is pretty easy to cross off as the answer because most of the time acetaminophen is still absorbed and effective for older adults. When we look at apixaban, she has AFib. So that does indicate her for apixaban long-term. It's a safer agent of all of the anticoagulants. And because she's on apixaban and aspirin, she probably needs omeprazole, not because she has GERD, but because she's at risk for a increased risk for a GI bleed. So then omeprazole is more likely indicated for her. So really that elimination brings us to gemfibrozil, which I don't see very frequently prescribed in the seniors clinic, but patients may come in on it. And maybe gemfibrozil was important for her in the past if she had uncontrolled diabetes and she had high triglycerides, but now her triglycerides are 50. So we shouldn't be afraid to discontinue the gemfibrozil and perhaps reevaluate her lipids in the future. So practice tip number 4 is adjust treatment goals based on comorbidities and frailty. And I've been talking a little bit about diabetes today, and this is one of the areas that we co-manage patients in the seniors clinic. But one of the amazing things, and I have the 88-2021 here because I put together this slide set a while back, but the 88-2022 has also been released. And when we think about these 88 guidelines, a while back, they weren't necessarily focused on older adults, but now there's an entire section on treating older adults, and there's a framework for goals of care for our older adult patients. And so this is super helpful in clinical practice. And I'm going to just show in larger font the 3 different sections. So for our older patients that are healthy and have good cognitive function, good quality of life, they have a longer remaining life expectancy. And so the A1c goal for those patients is less than 7 to 7.5 with the fasting preprandial glucose goal of 80 to 130, and then a bedtime goal of 80 to 180. In contrast, if the patient has more complex medical conditions, which is probably most of our patients at the seniors clinic, or they have 2+ instrumental ADL impairments or mild to moderate cognitive impairment, their A1c goal is more in conservative and higher. So that goal is less than 8, with a fasting blood glucose goal up to 150 and a bedtime goal still at 180. So this is most applicable to June, who has that mild dementia. In clinic, we typically use 100 as our lower fasting blood glucose goal because it's easier for patients to remember. So we typically will then adjust that to 100 to 150 instead of 90 to 150, and the bedtime glucose again 100 to 180. In those that are really complex, the guidelines actually now no longer recommend relying on the A1c. So if the patient has low quality of life, low remaining life expectancy, and high comorbidities, A1c is probably not the best way to monitor our patients. So we would typically then start looking at glucose management. So fasting blood glucose 100 to 180 and bedtime 110 to 200 would be the goal. And in most of the patients that we see, if their A1c is too tightly controlled, they may have hyperglycemia, but also hypoglycemia. And these kind of patients would be really a good fit for ordering a continuous glucose monitor so that you can really identify, are they having low blood glucose values any part of the day, and how high do they get? 200s may be reasonable for patients depending on their goals of care. The other really cool thing that is in the 2021 ADA guidelines is an algorithm for adjusting insulin. And this is often what we're doing in clinical practice as well, but it's a great reference for clinicians. They talk about changing the time of basal insulin from evening to morning. And this is really helpful for older adults. When you think about, for example, insulin glargine or Lantus, when it was approved, it was recommended to initiate in the evening. But what we started to see in clinical practice was patients would get hypoglycemic overnight. And so we started switching patients before this came out to morning dosing and found much better success because they were eating perhaps when they had the peak of that non-peak insulin. But switching just to the morning can make a big difference. Also, stopping sliding scale insulin, which doesn't work and is very difficult for patients to respond to. They also talk about titrating basal insulin based on fasting blood glucose and how to do that, taking 1 to 2 weeks to really adjust the therapy, and then also how to stop mealtime insulin and start non-insulin options to replace it. So for example, metformin or a GLP-1 agonist like Trulicity or a DPP-4 inhibitor like Tradjenta, an SGLT2 inhibitor, or potentially sulfonylureas, which can all help with postprandial blood glucose and can replace that short-acting insulin. So back to our patient, June. A year has gone by and you check her labs. Her creatinine clearance is now 28 and her A1c comes back at 5.8. Now 5.8 is good, right? So some people may just gloss right over that. But when we think about the goals of care for June, her A1c goal would be more similar to less than 8. So instead of glossing over that, we need to be more thoughtful about, is that potentially causing her hypoglycemia? And I would say, yes, it is. So in addition to stopping metformin due to the creatinine clearance level, which of the following drugs would be the most appropriate to stop at this time? Would you stop glyburide, insulin aspartate, insulin glargine, or glyburide and insulin aspart? So really, in this case, we would want to continue her insulin glargine because that's the least likely to cause hypoglycemia, although we may need to adjust the dose. But when you think about continuing short-acting insulin, that's the most likely to cause her to have hypoglycemia because she may not eat enough carbohydrates and have an increase in blood sugar enough to really cover that short-acting insulin. So in this case, you could stop the glyburide due to the low creatinine clearance. There's increased risk of hypoglycemia, or you could stop the glyburide and the short-acting insulin. Moving on to the last category, we have unnecessary OTC and supplemental use. So over-the-counters just kill me, honestly. I see so many patients taking these and they will take them instead of prescription drugs with relatively no evidence to support use. So I have a list here of the OTCs that I see frequently that may cause harm. So aspirin being one of them. A study just came out and found that 60% of patients over age 80 are still taking aspirin for primary prevention. And that is not indicated based on the new guidelines, not even indicated based on the 2015 guidelines. So aspirin, if it's for secondary prevention, it still causes harm, but it's indicated. But if it's for primary prevention, we really need to think about it. And if it's in combination with an anticoagulant, it's definitely increasing risk for harm. Ibuprofen and Naproxen, great choices if there's inflammation, but again, can have harms in older adults. Diphenhydramine for sure. Pseudoephedrine can cause urinary retention and difficulty urinating in patients with BPH. It also causes insomnia. It also causes tachycardia. So we think about that as well. And then omeprazole, our proton pump inhibitors, have quite a few harms. So those are on the list of, we have to be checking our patients for those agents because they can take them on their own. And we need to be really thoughtful if we have the patients continue them. Drugs that have no indication or data to support their use often are drugs like multivitamins or fish oils. Oh my gosh, drives me nuts. Probiotics, vitamin C, and almost everything else except vitamin D, B12, folate, calcium, iron, perhaps melatonin, diclofenac gel, acetaminophen, and the AREDS 2 vitamins, which are indicated for certain patients to prevent macular degeneration. So when we think about over-the-counter agents, it's really just trying to balance their medication overload with their prescription drugs. And is there evidence to support it? We don't even often know what's in that bottle. For example, melatonin, there's been many studies that have found inconsistencies in what's on the label with what's actually in the pills. So we do need to be thinking about these risks for our patients as well. So at the same appointment, you bring up June's use of low-dose aspirin, and it drives you crazy too. So you talk to June about it and her family. What outcomes from the Esprit trial are worsened with low-dose aspirin use in older adults and should be discussed with June? So if you look at the right, GERD, CV events, kidney impairment, and major bleeding and death are all potential adverse events that could occur with low-dose aspirin. But in the trial, they didn't specifically evaluate GERD or kidney impairment. So those would be ones that aren't necessarily found as evidence in that study. But they did look at CV events and found that placebo versus aspirin, there was not a reduction in CV events with aspirin, but there wasn't necessarily an increase either. And so the answer here is just major bleeding and death, which were increased with aspirin compared to placebo. So practice tip number 5 is to de-prescribe. And I love this comic on the right because I think it illustrates so frequently what happens when patients ask for drugs and are prescribed them. So it says, this prescription won't make you feel better, but it will stop your whining and make everyone else feel better. And so often that's what we see as one of the reasons that patients are prescribed medications, not with geriatricians necessarily, but often just in general practice. Another quote that I think illustrates this well is, starting medications is like the bliss of marriage, and stopping them is like the agony of divorce. So how do we de-prescribe and overcome some of these barriers? Well, one way to do this is to take one visit per year to perform a prescription drug checkup. This can be done and considered at the Medicare wellness visit. Often a good time to do it is after hospitalizations, when people are motivated to stop medications. And it's really helpful to have the patients bring the drugs from home if possible, because what I find often is patients get confused about what they're actually taking. And you may detect some really important things if you can view the medications. Also, discontinuation of drugs should be part of the normal prescribing process, and we should talk about it with patients. You know, we're going to start medications, but we need to de-prescribe medications as well and use shared decision making. As Bennett Parnes has said, he's always de-prescribed, but we haven't called it that until recently. So we now have a cool name to use, and it makes it a little bit more fun when we think about the effects that we might have for our patients. So we want to discuss the options with patients and family, the rationale for de-prescribing. The continuation of the drugs may cause harm. Discontinuation may cause harm as well. So for example, with statins, there's a lot of worry that if we stop a statin, patients might have an increased risk of cardiovascular events. And there are a couple studies that have looked at this, and there might potentially be an increased risk of cardiovascular events stopping a statin, but the risk is low. For example, in one study that increased the risk to 1 out of 112 patients had an event over 1 year. And then we want to educate and monitor for those potential harms of either of those two things, continuation or discontinuation. Some examples of drugs that I frequently see are good options to discontinue or de-prescribe would be in the first category. If they're inpatient and you're discharging them, can we stop their PPI that was started on the inpatient side for prophylaxis of stress ulcer? Can we stop their antipsychotics that were used for delirium? Can we stop the analgesics that were used acutely? Can we stop the laxatives that were used acutely? Can we stop their bronchodilator that was used acutely, or sleep agents for delirium or sleep issues in the hospital? And on the outpatient side, similarly, can we stop their PPIs? Can we stop the benzodiazepines? These are drugs that are frequently on your mind to de-prescribe. Can we stop their NSAIDs, their anticholinergics, their insulin, sedative hypnotics, antipsychotics, and statins? These are the low-hanging fruit drugs, the easier to describe to patients, but there are many other drugs that can be de-prescribed as well. And when we de-prescribe with our patients, sometimes they want a visual aid to help them understand why you're de-prescribing. So I use this website frequently, deprescribing.org. And this is out of Canada, but you can see it has some really good patient information tools in order to help them understand, is de-prescribing one of their drugs helpful for them? And you can see that different pictograms, things that can help them ensure a good night's sleep. And then the US has a de-prescribing network as well. So deprescribingresearch.org. They link to some other tools that are available in Australia and the UK None of these are copyright protected, so you can reprint as much as you want. They also have on the website articles about de-prescribing, and they offer webinars that are really great for researchers and clinicians, and they do have grant opportunities. Some other resources and evidence here. There are a couple other options. One is that I really like is the Comparing Treatment Options for Pain, the CTOP tool. So this is a visual. I know it's really hard to see probably on the screen, but this is for back pain, and it's a back pain calculator. And I think if your patient is cognitively intact and can understand comparisons of treatments, this is a really good website because it shows if they have low back pain, in green, how many patients will improve with treatment. So for example, exercise, you can see there on the left, has quite a bit of green. How many will improve with control is in the yellow, and how many do not improve with exercise is in the red. And you can see there that exercise has some green, oral NSAIDs has green, spinal manipulation has green, SNRI, duloxetine has green, but the rest don't, or we don't know for sure. And so this is helpful, I think, to show non-pharmacologic effects and who might respond compared to drug therapies. Practice tip number 6, tapering drugs is necessary when de-prescribing. So there are some drugs I have listed on this slide here. Tapering is needed often for drug therapies to prevent withdrawal symptoms. So that's drugs like benzos, antidepressants, antipsychotics, opioids, pregabalin. We want to prevent withdrawal symptoms like headache, nausea, vomiting, dizziness, or perhaps a worsening of their symptoms that they were previously taking. Drugs like clonidine, we have to taper because they can have very severe rebound hypertension if they stop that agent. And then drugs like estrogen, maybe they never had hot flashes, but now they do because we cold turkey stopped it. Other drugs, generally no taper is needed. So you and June agreed to de-prescribe other medications from her list, including her aspirin, ibuprofen, and omeprazole. What may occur though if June does not taper her omeprazole? And I have to tell you, maybe 10 years ago, we never tapered PPIs, but then we learned that they would have a response if they had been on them a while and cold turkey stopped their PPI. So is it C. diff? Is it dizziness and orthostasis? Is it severe heartburn? Or is it headache and anxiety? And in the case of PPIs, they are so effective at shutting down the proton pumps that if you stop them abruptly, patients will often have a very severe rebound heartburn effect. Even if they didn't have heartburn before, they will now. So it's similar to estrogen in that regard, and we do need to taper PPIs if the patients have been on them for quite some time. Practice tip number 7 is if you discontinue or de-prescribe, you also have to remember to discontinue the drugs at the pharmacy. And of course, we want to encourage proper disposal. So the reason that we want to discontinue it from the electronic medical record is we want to make sure everyone's on the same page that we stopped it. But it's also really important that the family and patient know to stop it. And it's also really important that the pharmacy knows to stop it, because what happens is they're taking that medication, they stop it, but now the pharmacy reorders it for them. They have it on automatic refill and they fill it. They call the patient electronically, say, come pick it up, and bam, the patient is back on that drug and you don't even know it because you stopped it in the electronic medical record, but the pharmacy restarted it. The patient restarted it unknowingly. So we have to ask the pharmacy to stop the auto refills and we have to deactivate the prescription often. And, you know, we are available to help with that. Your medical assistants can do that as well. And hopefully in the future, Cancel RX will help that as well. Safe disposal is important because patients may accumulate meds and then retake them on accident. So my grandmother that was in that picture, I went to her house a few years back and I opened up her fridge and she had penicillin ointment in there. And I was like, Grandma, this looks old. Are you still using it? And she said, well, I keep it just in case. And I looked and it expired in 1965. So, you know, I kept it because it's a pharmacy antique. I didn't dispose of it. But patients should dispose of their medications. And we have quite a few take back locations in the state of Colorado. Practice tip number 8, drugs are not the be-all end-all, so please utilize non-pharmacologic approaches. One of the things that I think is illustrated well in this Sloan Institute report is loneliness. Older adults with loneliness have higher prescription rates for benzodiazepines, sedatives, pain relievers, and antidepressants without relief. And that's because, as one of the physicians states, it's easier to prescribe a pill than to ask, why are you lonely? And to listen to the answer. So instead, we could be referring our patients to counseling or cognitive behavioral therapy or virtual reality. And we have these amazing resources at our seniors clinic. We feel really lucky. But if we don't have those resources, there's still social interventions that can be referred with community-based support programs. There's adult daycare, there's physical therapy, and if they have pain, exercise and heat and ice are often additional treatment options. So some key resources here that I had throughout the slide sets. I think this slide set will go out, and these are some of the key resources that I think are really helpful for practitioners. And I just want to say in conclusion, I know I'm speaking or preaching to the tabernacle choir here, and you all are well informed about our older adults, but we do want to work as a team. And it often takes that full entire team of geriatricians and nurses and psychologists and pharmacists and dentists and physical therapists and medical assistants and staff to be able to most effectively provide care for our patients and to avoid adverse drug events. So thank you for your time, and you feel free to email me, but I'm happy to take any questions, Dr. Hildreth, if there are some in the chat.
Yes, thank you, Sunny. That was fantastic. Wonderful talk and great resources. So there are a few questions in the chat. So going back to, I think this was related to when you were talking about possibly ineffective or not needed. And the question was about H2 blockers.
That's a great question. So when we look at the adverse effects of PPIs and H2 blockers, the only one we have over the counter right now is famotidine or Pepcid. Famotidine or even ranitidine when it was on the market, those are going to have lower risks associated with them than PPIs because they're not quite as effective as reducing that acid, but they still have some of the same adverse effects. So H2 blockers can still contribute to vitamin B12 deficiency. And there is some evidence they increase the risk for delirium, but not dementia. So when we think about the risks of PPIs, those risks, and again, it's typically chronic use, but PPI risks include B12 deficiency, also magnesium deficiency, also risks potentially for cognitive impairment, kidney impairment, and then also things like pneumonia and C. diff increase risk. So PPIs have much higher risk. I didn't put H2 blockers on there mainly because they are much better tolerated long-term. They're just not as effective at preventing GI bleeding. So we typically see PPIs being used more frequently. I hope that answered the question.
Thank you. Another one kind of in the same vein is when you talked about tapering PPI. So the question is, what is your taper for omeprazole and how slow do you go with that?
That's a great question. When tapering PPIs, there are some resources on the De-Prescribing.org website. So they will have an actual tapering algorithm for patients depending on what dose of PPI they're on. But typically, I think about dosing the PPI. It depends on what their starting dose is. So for example, if they're on omeprazole 40 milligrams, then I will recommend that they decrease to 20 milligrams. If they're on 20 milligrams and we can get a 10, then we'll go to 10. But typically, it's cutting the dose in half until you can get to the lowest dose. That may be done over more like a 2 to 4 week period, depending on how the patient responds. And then you're going to lower the amount of days that they're taking the medication. And this is where it gets tricky and they may need a calendar. So for example, instead of taking that lowest dose 7 days a week, you'll go to every other day. And then you'll go to a couple days a week. And then you'll go to discontinue it. And that may need to take place over 3 months. So there's no gold standard for de-prescribing the PPIs. It's mainly monitoring, and if the patient has increased acid reflux, then you might need to slow down the taper. And again, there's no like serious harm. So if you have to just stop the PPI at whatever dose, you can. It's just they might have increased heartburn for a couple of weeks and not be able to tolerate it.
Another question related to Carvedilol and potential for urinary side effects. Just saying that, you know, most patients are on it for CAD, MI, stent, and by guidelines, they should stay on it. Do you suggest a different beta blocker if there are urinary complaints?
Yes, that's exactly what I would do. So if they are on Carvedilol indicated for heart failure or for hypertension or post-MI, Carvedilol is the only one that has the alpha blockade included in the mechanism compared to other beta blockers. So I would choose a cardioselective beta blocker that doesn't have alpha blockade effects, like metoprolol is a good example. And that's probably our go-to for switching to. Metoprolol is inexpensive and is one of the also evidence-based beta blockers post-MI for hypertension and for heart failure.
Okay, thanks. Well, we're at 8:30. I don't know if you have time for one more question. And
Sure.
this is, if we write an electronic prescription to a pharmacy and then we want the pharmacy to DC, so you're starting, for the example given is starting mirabegron, stopping trospium that they had on file. How confident are you that the pharmacy actually stops the one that's being stopped?
I'm not confident. So, so if it's like UC Health and Epic will actually discontinue it at the pharmacy. But if it's outside of UC Health, for example, they go to a retail pharmacy like Walgreens, you have to call Walgreens and you have to say discontinue. If you just type in the notes, discontinue trospium, it's probably not going to happen because that will get left in a field that's in their electronic prescribing system that isn't visualized by the pharmacist. So it's really important if it's a drug like trospium where, you know, plus minus on risks, I would, if you want to feel comfortable, you have to call them and that's difficult to do too. So we will often leave a message, but in the outside med tabs of Epic, you can look at fulfillment history and you can see if it was refilled for the patient at a later date. Nothing is great about that system. It's very cumbersome. So we're waiting on Cancel RX as an electronic method to submit and then actually deactivate the script at the pharmacy level. It's still not accessible quite yet in 2022.
Great. Thank you so much. We're at time, so people need to get onto the division meeting. Sunny, thank you again so much. This was really, really helpful, and see everybody in a couple of weeks for next Grand Rounds.
All right, thank you.